Hello, everybody. We're going to talk about shock and sepsis, some of my favorite topics. So this is module 7 in the critical care course. And we are first going to talk about, I will let you pause to look at the objectives. Basically, we're going to go over the different types of shock, how you treat, how you notice what's happening, how you treat it, and the things you can do as a nurse, okay, to prevent it from getting worse. But ultimately, we're going to say, like, what is shock? And I want you guys to be able to easily define it, okay? That's biggest goal for me. So there are different types of shock, but first we're going to talk shock in general. It's a life-threatening condition. It is the basic definition of what shock is the inability to get oxygen and nutrients to the tissues. And it could be caused by, like I said, different types of things, okay? But your inability to get oxygen and nutrients to the tissues. So I want y'all to realize that everybody dies ultimately from one form of shock, ultimately, okay? So it's our job as nurses that, especially in the critical care setting, that if we identify that one of these forms is happening, that we can intervene and stop it before it happens, okay? So remember, shock is not a one-size-fits-all condition. It's a spectrum, okay, with different phases and underlying causes, okay? So you're going to, there's 4 different types. And I also want to preface this with some people organize shock into different categories, but these are the 4 that we're going to go with and how we organize it. Some people will say neurogenic, anaphylactic, and septic shock are their own forms, but they're actually forms of distributive shock. So that's kind of important to say, okay? So first we're going to talk about hypovolemic shock, which is basically drought in the body, a severe fluid deficit that hampers the circulation, okay? This, then there's cardiogenic shock, where the heart itself is the failing pump. So genic, meaning the beginning. So it's caused from the heart's inability to pump the blood. Okay. That's, a similar way to say that it's like the power plant malfunctioning and cutting off electricity to the city, but cutting off the blood supply. Right. So then we're going to talk about distributive shock, which is more like mismanaged distribution system, where resources are available, but they're not reaching the right places. Okay. So like we have the goods, but we can't get them physically to the location because of widespread vasodilation, okay, increased capillary permeability. Those are some of the reasons. Okay, so this one includes neurogenic shock, which is loss of sympathetic tone, anaphylactic shock, which is caused from severe allergic reactions, and septic shock, which is caused from overwhelming infections in the bloodstream and in the body. And then the last thing, but we're not going to focus a lot on it today, is obstructive shock, which is a physical blockage that impedes the blood flow, like a dam blocking a river. Okay. Understanding these different types is going to equip you guys with the knowledge to identify and manage each one of these effectively, or at least that's my goal. So a little bit more about hypovolemic shock. Okay. So this is the one that a lot of people think of at first, either this or septic shock, okay? But hypovolemic shock is, and it involves a decrease in the volume of circulating blood or fluids, okay? So imagine your blood vessels are rivers, okay, in a country, in a land, okay? So hypovolemia is like a severe drought that causes those rivers to run dry, okay? So there's no liquid in the tubes, right? So the common causes include hemorrhage, which is like bleeding out from trauma, or gastrointestinal bleeding, like a GI bleed. Okay. Some of the other big causes are dehydration due to excessive vomiting or diarrhea, which depletes the fluid volume in your circulatory system. So burns is another one. So burns, though they can be, we're going to talk a little bit more about burns in the emergency nursing trauma module, but burns, you lose a lot of fluids really quickly, in plasma specifically, okay? And then also like third spacing remember third spacing, that refers to the fluid shifting from the vascular space to the interstitial space, okay? So like ascites and severe edema. So again, hypovolemic shock is the lack of fluid in the tubes. Now, could it be because the tubes are bleeding out into, the outside of the body? Yes. Could it be because there's so much fluid being excreted by the kidneys that you can't keep enough fluid in the tubes? Yes. Could it also be because it's interstitial third spacing, and so the fluid is in like the interstitial spaces versus the inside the tubes and the vascular spaces? Yeah. So all of those, it's a lack of fluid blood in the tubes. Okay. I hope that makes sense. So the pathophysiology of it. Okay. So understanding that is like piecing together chain reaction. Okay. So it starts with a decrease. So what happens is the way it starts is a decreased intravascular volume. Okay. So this is going to reduce the venous return to the heart. Okay. So there's less water flowing to the pump station. Okay. So after that, what consequently happens is that there's a decreased stroke volume or in cardiac output. So there's not a lot of fluid going in, so the heart can't pump out what it doesn't receive, right? Okay. So this results in impaired tissue perfusion, meaning that the organs and tissues aren't getting that oxygen and nutrients that they need. Okay. So the body doesn't take this lying down. Okay. The body's like, hey, no. Okay. So what it's going to do is it's going to try to compensate. Okay. So it's going to increase the heart rate. It's going to try to constrict the blood vessels to maintain that blood pressure to get the blood to those vital organs. Okay. So it's not a temporary fix. I mean, these are temporary fixes. They are temporary fixes. Your body cannot do that forever. Okay. So without addressing the root cause of the fluid loss, eventually the system isn't going to be able to maintain the perfusion and it's just going to fail. And that means lose all vascular tone, lose all of the ability to perfuse the brain, the organ, all the organs, the heart, the lungs, everything, and it subsequently will end in death. So we want to fix it, okay? So clinically, clinically looking at your patients, hypovolemic shock presents with signs that are similar to like an SOS system, like going out of whack. Okay. So hypotension occurs because there's just simply not enough fluid in the tubes to maintain the pressure. Okay. So, and then that subsequently causes the heart to beat faster and to try to keep what little is in the tubes reaching the places. So what are you going to see in your patients? You're going to see cool, clammy skin. Remember how I say that the body prioritizes where it's going to send your blood, right? At the top of the list, brain, heart, lungs. Those are the most vital things. The last thing it's going to send your blood, where you're just going to send your blood to, if it's got to prioritize like what's more important, is your skin. So you're going to see the cool, clammy skin, maybe mottled skin, a delayed cap refill, those kind of things, because your body is shunting blood away from the skin to the vital organs, okay? So the next thing is decreased urine output, because the next thing that your body's like, hey, don't care about is the kidneys. So it's going to stop sending blood to the kidneys. And so you're not going to be producing urine. Okay. So when your kidneys don't get perfusion, like they sense the low perfusion, they're going to conserve and maintain the volume. So they're going to stop excreting urine. Okay. I hope that makes sense. So another thing you might see is an altered mental status, okay? And that can range from anxiety to confusion, okay? So when the brain doesn't receive enough oxygen and nutrients, that's what happens, okay? But that's kind of a later stage. You might also feel weak peripheral pulses because there's just a decrease in the blood flow and the amount. So it's just going to be weak, sometimes maybe thready, okay? And like I said, delay cap refill. Those are things you're going to see. So you need to recognize these signs and be able to read what's going on with your patient so that you can intervene. So what do we do to treat these? Okay. It's all about replenishing what's lost and fixing the leak if there's a leak. Okay. So fluid resuscitation with crystalloids is the first step. Okay. It's like now it's the first step in everything but trauma related bleeding out. Let me just preface that. We're going to go more of that in the trauma lecture, but like if you are losing blood and you lost a whole lot of blood and so we're not getting oxygen to places, what good is putting water in the tubes? It can't carry oxygen. You're still not going to get oxygen. So we need to replace you with blood. But if it's because you're losing fluids due to like diarrhea or emesis or third spacing or whatever, we're going to replenish you with crystalloids, okay, like normal saline, okay? So in case of significant blood loss, like I said, blood transfusions are necessary. Okay, so that's the little differences. Okay, we also want to identify and stop the source of fluid loss. Okay, so big thing. Okay, so we want to treat the diarrhea. Okay, we want to also provide oxygen therapy because we want to, whatever does get into our system, we want to make sure the blood is richly oxygenated, because if we have lack of blood, then we want to make sure what little is in there is really well oxygenated so it's getting to the tissues, right? We also might be using medications like vasopressors, okay? So to maintain that blood pressure. But for hypovolemic shock, number one is fluid resuscitation, blood transfusion. We need to add fluids, okay? So, the only other thing I was going to say, on this page, you see a picture. There's a pressure bag around the blood thing. So a lot of times when you're bleeding out, we're going to give you, we want to rapidly infuse you. Okay. So a lot of times we'll use a pressure bag. I mean, you are not supposed to do this, but in real life, you will literally see nurses squeezing the bags with their hands just to get it into the system fast. You'll see EMS do that too. Should you? No, but they do. On the right, there's a picture of a level 1 infuser. This will rapidly infuse typically warmed fluids into the patient really, really quickly. And like I said, if you are in an ER, OR, you will know these. Not as common in the ICUs, but it can be that you can get them in the ICUs, but they're very common in ERs and ORs. Okay, so fluid volume. When it comes to fluid therapy, you need to choose the right fluid type, okay? But that's like selecting the appropriate fuel for the different type of car or engine you need. Like not everybody needs the same thing based off of what's going on, okay? So crystalloids, such as normal saline and lactated ringers, are often the first choice because they're readily available. They're readily available and they're pretty effective, okay, in increasing the intravascular volume. Colloids like albumin, so those are like larger molecules that stay in the vascular space longer. They're more expensive and they have their own risks. That's like premium fuel if you want to like use that metaphor. Okay, so they can be used, but it needs to be in a specific situation. Fluids are typically administered IV, like I said, sometimes requiring large bore IVs or central lines for that rapid infusion. So if you get a patient that only has like a 24 gauge in their hand, like a little baby vein, one of the nursing interventions is large bore IVs, 18 gauge or bigger. So like 16 and a 14 gauge would be amazing, but 18 gauge is kind of the gold standard for what we consider large bore. But anyways, okay. So you also, as a nurse, need to be monitoring the patient's response to the fluid resuscitation. Okay. So we're going to be looking for improvements in vital signs. We're going to be looking for increased urine output. We're going to be looking for improvement in mental status. That's all the signs that basically things are improving and we are perfusing the patient again. Okay. So be vigilant for some complications that might arise from fluid overload because we may have given them too much, okay? So what are signs of fluid overload? Crackles in the lungs, edema, JVD, those kind of things, right? So it's a delicate balance, okay? But in the initial, we're just going to be flooding with fluids. We'll deal with fluid overload later if that occurs. Okay, so a little bit about blood transfusions. We want to remind you, typically levels below 7, we're definitely going to transfuse, but we might transfuse above for other conditions, whatever. So there's a little thing on here just to remember the compatibility of blood products to be given. I will tell you, a trauma patient coming in, male versus female, females need O negative, okay, 1000% of the time. We prefer O negative for everybody, but sometimes we don't have that ability. We will give a male patient O positive if it's the only thing. So we've ran into issues in the past where, especially like during COVID and stuff when nobody was donating blood and all this kind of stuff, where we can give O positive to any male that walks in because that RH factor, if you guys remember, it's really only worrisome after the fact if you have like a baby and like it attacks the baby from OB. Okay, so they will give O positive blood to males. They won't give it to females, especially if you're childbearing age. Just in the case that you are A, B, or O, or AB negative RH factor. We don't have time to type and cross match you in a trauma situation. We're just going to give you what we call, some places they call them stat blocks. We're just going to give you O negative and just shove it in your system because that's what you need. Okay. We have little coolers, refrigerators in trauma centers. We have them in each shock room. It's part of kind of like your daily checks at the beginning of your shift. You go and you check, make sure that you have stat blocks of blood, packed red blood cells typically. I mean, we rapidly get them, and you want to make sure you have at least 2 units in every room at all times because as soon as you use it, you're going to need it again for another patient. So you should be calling down to the blood bank and getting more if you've used it on your patient, just so it's ready for the next one. But we just keep them in there so we don't even have to delay giving it to you if you really need a massive transfusion. So In the case of the massive blood loss, we want to transfuse packed red blood cells to restore that oxygen carrying capacity. I will also tell you, if you work in a major level 1 trauma center in an ER, EMS, pretty much almost all EMSs everywhere. Some EMSs carry blood on their ambulances, and I think it's amazing. In the Houston area, it's HFD does not have it. Cypress Creek, the last time I checked, they were one of the few that were carrying it, and it saves lives. It really does. But when they come in, when a trauma patient comes in from the outside, I want you guys to remember that they have limited resources on the ambulance. They can only do what they can do. And so if you're bleeding out or hypovolemic, they're going to give you what they can. They're going to give you fluids. Even though it doesn't have oxygen capacity, at least it will maintain the perfusion for the rest of the red blood cells that have oxygen carrying capacity that's already in the system that you still have left, because they want to at least maintain the pressure so they can perfuse what little you have in there, right? But I will tell you, if you work in a level 1 trauma center and a trauma surgeon walks into your room and sees fluids hanging, even if it's not your fault, even if they just got off the ambulance and they were just transferred to your stretcher, they're going to yell to discontinue the fluids. Like, why are we perfusing them with fluids? We need to be giving them blood products. So that's just one of the things you just kind of have to be prepared for, and you'll learn that when you guys get oriented. But if they are hypovolemic because of blood loss, they need blood. The biggest thing I want y'all to remember, they need blood. Okay. So but even if you give any sort of blood, you want to always monitor for transfusion reactions. Okay. So remember what those transfusion reactions are. So it could be increased in temperature, right? So it could be like chills or an actual like fever. Okay. Patients can also have allergic reaction. It could be mild, like hives, itching, flushing. It could also be severe, like anaphylaxis. They can also have like back pain, dark urine, hypotension, acute kidney injury. So that's truly when the receiver's immune system is attacking the transfused red blood cells. You can also have a delayed hemolytic reaction. Okay, so that can recur days and weeks after transfusion. It doesn't happen all the time, obviously, but it can happen. But there's lots of other things that you're going to be monitoring very closely after you give them the blood products. So effects of hypovolemia on organs. So these are all the sad organs because they're not getting blood, right? Okay, so hypovolemia doesn't just affect one part of the body. It's systemic. It's all over, okay? So it's going to lead to a domino effect of organ failure. What do I say? The first organ that you're probably going to notice besides the skin, kidneys, right? So the cardiovascular system might develop arrhythmias due to electrolyte imbalances because of the lack of blood, okay? Especially for flooding them with fluids and not blood, and then it's all out of whack, okay? Also ischemia from reduced oxygen delivery, okay? So the renal system is the one I say it's particularly vulnerable. Decreased perfusion can lead to acute kidney injury. You're not giving blood and oxygen to the kidney. Well, what happens to the tissue of the kidney? It starts dying, right? Like, that's not cool. It's not just that it's not filtering and creating urine, it's not getting blood and oxygen itself, right? So neurologically, patients, like I said, can become confused, or they could go into actually a coma, okay, because the blood and oxygen is not getting to the brain, so the brain's not going to work. So that's like having a massive stroke. That's not okay. But it's going to be complete, like, global of the brain. It's not going to be in like one area versus the other. Your GI system is also going to slow down, reducing the motility, potentially leading to an ileus, okay? So respiratory tachypnea is going to occur because you're trying to compensate for the metabolic acidosis. And so we want to a lot of times these patients end up mechanically ventilated so that we can help chill the system out and regain homeostasis after the fact, but not always. But yeah, so vital sign monitoring, you are going to bare minimum be assessing every few minutes, but I'm hoping that you can get an art line in really fast and all sorts of other things. Okay. So you want to be monitoring these and keeping that super close eye on, all the different hemodynamic monitoring that you can. Okay. The recommendation is like every 5 to 15 minutes until your patient is stabilized. So, and that's pretty common in any critical situation. Again, unless you're going to follow your policy of wherever you work. If your patient is critical, you're probably going to be doing vitals. You can change the settings, and you could always do it more frequently, but a lot of times it's every 5 minutes. I mean, every 3, you're not going to get accurate, or every 2, but sometimes you have to. But bare minimum every 5 minutes 5 to 15 minutes, at least every 15 minutes until the patient is stabilized, but it's probably gonna be every 5. But again, that's kind of your choice as a nurse, unless there's a policy specific on it. Again, pay attention to the blood pressure and the map. The map, way more important if you have that art line and everything to get in there and get very specific things. The CVP is also going to help you. Think to yourself, what is your CVP going to be if you're hypovolemic? It's going to be low, right? Yes, because you need fluid volume, right? Okay. So those advanced diagnostic tools, okay, you need them. Okay, so we really want a CVP if we can get one as quickly as possible, but that takes time to place the lines for it, right? Okay, so interpreting the vital signs, just because you have a low blood pressure doesn't mean that the cause of it is because of the fluid, right? But if you have lost a lot of blood or fluid, then you would expect your CVP to be low. But if your CVP is high, then obviously what we need to switch to is vasopressors, right? To maintain the blood pressure on the map. So just remember that. It guides all the hemodynamic monitoring is going to guide your decision-making and how you treat the patient and what you do next, okay? So now let's talk about a different type of shock, cardiogenic shock. What causes it, okay? So I want you to think of the heart as the main engine of the body, the main pump, okay? So when the engine and pump fails, everything in the entire body grinds to a halt. Like nothing's going to work, right? It's the main source. So a heart attack or an MI, okay, is one of the primary causes of cardiogenic shock, okay? So this is where shock, the inability to get blood and oxygen to all your organs and tissues, comes from a problem with the actual pump itself, cardiogenic shock, okay? So, like I said, an MI is one of the primary causes of this. And again, just as a refresher, that's where there's a blockage of the coronary arteries that damages the heart muscle. So the heart muscle can't squeeze the blood out, okay? So cardiomyopathy, so myo, muscle, pathy, issues with the heart muscle. That's another thing. So where the heart muscle is weakened, okay, over time, and that reduces the pumping efficiency. So also arrhythmias can disrupt the heart's rhythm, not able to squeeze the stuff out. So like VTach, VFib, those kind of things. Valvular heart diseases might impede the blood flow through the heart. Okay. That also can cause cardiogenic shock. And then lastly, severe heart failure. So this represents a culmination of various cardiac conditions that leads to the heart's inability to meet the demands of the body. Okay. So remember, identify the specific cause would be very beneficial in you fixing it, right? So like if they're having an MI, let's restore the blood flow to the heart. If they're having heart failure and so the heart is very weak in its squeeze, we need to give like an inotrope or something to make the squeeze harder. So maybe medication related in how we fix it. Or they may need a pacemaker or whatever the case may be. So pathophysiology. In cardiogenic shock, the heart's impaired pumping ability leads to reduced cardiac output. That's the fancy way of saying it, right? Okay, so the body attempts to compensate through vasoconstriction. Okay, so it's going to try to make the vessels smaller, okay, so that to maintain that blood pressure. But that causes an increased afterload, which if you remember what afterload is the resistance of the heart. The heart must overcome to eject blood. So it's like the pressure after it, right? So, which would then cause more issues with the heart's ability to pump, if that makes sense. So the pump's already weak and it's pushing up against increased pressure, so it's harder to get it out. So this kind of is like a snowball effect of bad things happening. So to increase the workload, this increases the workload of the heart, basically, and increases the oxygen demand of the heart. So that's going to further strain what is already happening to the heart and its ability to pump, okay? So this is going to also lead to worsening ischemia around the body, and it's like a vicious cycle, okay? So what we have to do is break the cycle. So we need to do, the interventions need to be geared toward reducing that heart's workload and improving the ability to pump effectively, okay? Like I already said. So treatment, like I said, inotropes like dopamine, dobutamine, vasodilators. We're going to be trying to squeeze that heart a little bit more and dilate the blood vessel so it's not working so hard to pump it out, okay? So, but we may be doing some non-pharmacological interventions. So we might actually be putting in an aortic balloon pump to help pump the blood beyond what the heart is capable of doing. And then we, of course, if the problem is like an MI, we need to open up the blood flow so that the heart can pump better again, right? It also might be like if they're having arrhythmias, fixing the arrhythmia through shock, defibrillation, or meds, whatever the case may be. Okay, so again, some dopamine. So we're going to talk a little bit specifically. It's a little refresher on dopamine. Dopamine is a key medication in managing cardiogenic shock that is due to like the heart's, we're not talking about MIs, but due to like its weakness and its ability to pump. Okay, so it's indicated for those patients with hypotension and low cardiac output. Okay, so dosage typically starts 2 to 5 mics per kg per minute. You don't have to memorize that, but just know that there's always a starting dose and you're going to titrate. You're going to administer it IV, okay, and you're going to titrate it based off of the patient's response, and they need to be hemodynamically monitored, okay. Remember, dopamine works by stimulating those beta-1 adrenergic receptors, okay, which increases the heart rate and the squeeze, the contractility, the force, the ability to squeeze. It's a stronger squeeze of the heart, okay. So at the higher doses, it also stimulates those alpha receptors, which can cause vasoconstriction, which can help raise the blood pressure, but it, again, might increase the heart's workload. So we kind of have to balance those kind of things. Side effects include tachyarrhythmias, hypertension, potential tissue necrosis if it extravagates. So like we want to make sure it's in a large bore or central line. We really want it in a central line, but we can start it out in a large bore IV, but we're not going to be giving this sucker in the hand or forearm. Okay. Like, no. Cause if it even leaks out even a little bit and goes into the tissue, it's going to cause massive vasoconstriction in that area. And you're just going to cause tissue necrosis and they'll end up with an amputation. No. Okay. So now let's talk about distributive shock. So now some people don't just label distributive shock as distributive shock. They just completely talk neuro, anaphylactic, and septic shock separately, but those are all 3 forms of distributive shock. Okay, so this is a category where the problem isn't the amount of blood, but where it's actually, okay, so it's not about the amount of blood, but where it's going or not going. So this is about the distribution of the blood. Okay, so like this is akin to, like, for an example, like you have a well-stocked warehouse, like you have tons of supplies, which the warehouse is the body, but the transportation strike is going on. So we don't have any cars to get these goods anywhere, so, right? Or the roads aren't working good. Okay. So that's like vasodilation or like preventing the blood from reaching its access to the stores. Okay, so the common pathophysiology involves the widespread vasodilation and increased capillary permeability. What that means is the capillaries are way more leaky. So they leak a whole lot more than they normally do. So there's a lot more fluid in the interstitial space, and then they don't suck it back up like they should. Okay, so that leads to relative hypovolemia despite normal or increased blood volume. So the main types are neurogenic shock, and that results from spinal cord injuries that disrupt the sympathetic nervous system control. We're going to go over a little bit more over each of these in a minute. Anaphylactic shock, that's caused by severe reactions leading to massive histamine release. And then there's septic shock, which is probably the most common that people already kind of know about going into this lecture. And that comes from overwhelming infections that trigger a systemic inflammation in the body. Okay. So you guys need to understand the different types because, again, it's crucial because you need to know what treatments you need to do for each different thing. So more on neurogenic shock. So neurogenic shock is unique, okay, among all the shocks, okay? So its cause includes spinal cord injuries and spinal anesthesia that disrupts the sympathetic nervous system pathways, okay? So this disruption leads to a loss of sympathetic tone. So without sympathetic tone, what happens is there's just massive vasodilation in all your blood vessels, okay? So that in pooling of the blood in your periphery. So unlike other shock types where the heart speeds up to compensate, neurogenic shock often presents with bradycardia because of unopposed parasympathetic stimulation, okay? So clinically, patients will have hypotension, bradycardia, warm, dry skin, because remember the blood is pooling, right? So they're going to have warm skin due to that vasodilation, okay? So recognizing these signs is essential because the treatment focuses on restoring sympathetic tone and supporting cardiovascular function. Now let's talk about anaphylactic shock. This is the other one that you probably are more familiar with than the others. So this is like a full-scale alarm system gone haywire. It's like warning invader when it's not. It's like your alarm system going off in your house, and like all the doors want to automatically shut and to keep like bad people out, and you're like, it's just me, I live here, like don't lock me out. So that's like your body's overreaction to some foreign invader or allergy, right? Okay. So common causes include medications like penicillin and foods like peanuts, shellfish, and some like insect stings like bees and wasps. But technically, anything that people can be allergic to can cause an anaphylactic reaction. Okay, but those are just like the more common ones. So the pathophysiology includes IgE-mediated immune response, leading to the release of histamines and other mediators. When your body releases the histamines and mediators, that causes vasodilation and increased capillary permeability, airway edema, and bronchospasm. So this is like crazy overreaction of your immune system, and it's like trying to like close the borders, not let anything in. That's why your airway shuts off and like all this kind of stuff, because I want to get everything out of my system. I don't want these foreign invaders in. Okay, so clinically what you're going to see in your patients, they're going to have difficulty breathing, swelling around the face or throat. Okay, this is a big one. Hives, possibly, and hypotension. You need to immediately recognize what's going on in the because treatment is critical for this. Okay. Now, how do we treat anaphylaxis? Epi. Okay. So treating anaphylactic shock requires you to notice what it is and do immediate action. Okay. Immediate identification allows for that prompt intervention, like go get the EpiPen. Okay. So epinephrine is the first line treatment. And so what it does is it acts to rapidly constrict blood vessels, and it also relaxes the airway muscles, and it reduces the swelling. So it's like hitting the emergency shutdown, like to stop a malfunctioning system. Sorry, I can get that out. So it's like emergency shut off, like stop it, stop being stupid body, and like let me breathe kind of thing. Okay. So we administer it IM, okay, into the mid or outer thigh for quick absorption. Okay, we also are going to treat this with airway management. Okay, so you may need to prepare for advanced interventions if airway edema progresses. You need to be watching. You can have refractory respiratory issues, so you may give epi and it may work for a little bit, and then all of a sudden things start getting worse again. You have to do repeated doses, and we may just have to intubate you because we're not able to maintain your airway otherwise. Okay. And then we could also give antihistamines and steroids to mitigate that allergic response. Okay. Now let's talk about septic shock. We're going to get into septic shock, but we also need to talk about sepsis. Sepsis and septic shock are not the same. Sepsis can progress into septic shock. Let's just preface that with that. Sepsis is the condition, then septic shock is the condition getting to the point where you're not able to perfuse your vital organs. Okay. So we're going to start off with septic shock, then we're going to move back into sepsis, and then we're going to come back to septic shock. So just go with me on this journey. Okay. So septic shock, okay, is an overwhelming infection that causes the body's immune system, the defenses, to go into overdrive, resulting in like the collateral damage of all the rest of the organs. So it can be bacterial, fungal, typically. That's more common. So the pathophysiology involves a systemic inflammatory response where the body's attempt to fight off that infection leads to widespread vasodilation. Because remember, we're still talking about distributive shock. So it's massive vasodilation. So that's septic shock is a form of distributive shock. Okay. So that infection leads to vasodilation and increased capillary permeability. Okay. This is going to affect multiple systems. The immune system becomes dysregulated because it cannot contain the infection effectively. The inflammatory response damages the tissues and organs. Coagulation systems may be activated inappropriately, leading to microclots, which that's DIC. We're going to talk about that a little bit later. That's disseminated intravascular coagulation. Further impairing blood flow. You don't have to know about DIC right now. We'll learn about it more in a lecture in the future, but just know that sepsis can cause clots. Okay, just know that. So you guys need to recognize a patient is going into septic shock early, and because we got to get this sucker under control. Okay. And a lot of places have very specific protocols for dealing with a suspected sepsis and septic shock. Okay. So the goal is what we call this early goal-directed therapy. Okay, so managing septic shock requires coordination, multidisciplinary approach. Okay, like this is not just nurses and physicians; it's everybody on board. Okay, there are a lot of facilities that even have a code sepsis, just like a code stroke, a code, like a trauma code, whatever. Like they will have a code sepsis. So early goal-directed therapy focuses on optimizing the cardiac preload, the cardiac afterload, and the contractility to balance the oxygen delivery and demand. That's big and fancy for what we're about to talk about. Okay, so what are some of the laboratory tests that test for if your patient has septic shock or is septic? This is kind of both. So blood cultures. Before we start antibiotics, we always want blood cultures, because what we're going to do if we're suspecting, we need to get antibiotics on board on these patients like ASAP. We don't need to delay. We need to start killing this bacteria that's causing this issue, right? But the problem is we're going to give a broad spectrum antibiotic, something that we think is going to cover it, but we don't know yet, right? So we need to make sure that we're getting cultures of the actual organism before it goes down to like lower levels where we may or may not be able to detect it, okay? Because we're going to take that culture, and this is how I explain it to patients when we do blood cultures. We're going to take some of your blood, and we're going to put it into this bottle. I'm not filling up the bottle all the way. They always think that you're taking away too much blood. We're only putting a little bit of blood in there. Don't worry. Don't freak out. And we're going to send these bottles to the lab where they're going to put them in an environment where if something's going to grow, it's going to grow. Okay. They're going to wait 3 days to make sure something is going to grow in there. If at the end of 3 days, nothing has started growing yet, then we're good. Everything's fine. But if during that time something starts growing, the machine that it's in is going to start ding, 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 dinging. And they're going to take that bottle out, and then they're going to isolate whatever is growing, and they're going to test it to figure out exactly what type of bacteria it is. And then what they're going to do. So that's a call to culture. If you've ever heard of culture and sensitivity, the sensitivity part is once we do the culture and we identify the exact organism that is causing this infection, we are now going to do what's called a sensitivity. We're going to grow that organism all over the place, and we're going to take samples of all different types of antibiotics, right? And we're going to put them on each one of these, and we're going to see what kills that bacteria the fastest and the best. Okay, so that's the sensitivity. And so then what we're going to do is we're going to say antibiotic F is the one that, out of A, B, C, D, E, F, G, H, I, J, K, F is the one that worked the best. Okay, so then we're going to go back, the lab is going to let you know, and the physician's going to look back in the system and say, well, what antibiotics do we start this patient on? Is F the same? Oh, F is the same. Okay, good. We're treating it. It should be good. Oh, F is not the same. Okay, well, we need to switch the antibiotics right now so that we make sure we're killing this organism. I hope that makes sense for you guys. So that's why we need to do blood cultures, and we need to get it before we start those antibiotics, because as soon as the antibiotics go in, they start killing the thing. And you might think, well, then what does it matter if it kills it? Well, it may not kill it completely, right? But it may be so low that we can't detect it anymore, and then we won't be able to identify it, and we won't be able to have sensitivity to it to know what's best to do it. So we need to get the cultures before, okay? And it's not just blood cultures. We're going to be taking cultures from everything that we can think could be the source of infection. So we want respiratory secretions to test for flu, RSV, that kind of stuff, because we want to be able to rule them out. If they have a wound, we want to do wound cultures. If we think it's a UTI that's causing sepsis, we want urine cultures. We want everything. If we think it's meningitis, we need a lumbar puncture to get CSF out for culture of that too, okay? Plus the blood culture. So we need to culture everything before we start antibiotics. The problem is we need to start antibiotics like within minutes. So this is like a race. And that's why I love septic patients, especially in the ER. It's like, oh, they may be septic, and I have 5,000 things to do really, really quickly. And it's like playing like a video game in my mind. It's like, boom, boom, boom. Let's see if I can beat the clock. I don't know. I think it's fun. So I need to culture everything, get everything done. We're also going to do a chest x-ray, blah, blah, blah. And then I need to get antibiotics on this person. Okay. So we're going to be taking blood cultures, but also cultures of everything. We're also going to get a lactate. Of course, we're going to get like a CBC because we want to know what the white count is, right? We want to know, I would also honestly, I would like ABG because I want to know if they're acidotic and all these other things because I want to treat it all. But I really want to know a lactate level. Okay, so a lactate lets you know if there has been basically decrease in oxygen consumption from your organs. So if they have been deprived of oxygen, even just minimally, your lactate is going to go up, okay? So your lactate levels, if it's elevated, woo, that's a big one. Okay, so if they have a high white count, their lactate's high, they're in their blood pressure, they have a fever, a suspected infection, their blood pressure is like low end of normal or low, and their heart rate's high, they're febrile, any of those things like that, this patient's septic. Okay, but anyways, so back to my story. Sorry, kind of going off on a tangent. So again, we want to measure those lactate levels to assess that tissue hypoperfusion, because it's going to let us know if that lactate is elevated. That means that the tissues have been hypoperfused, meaning they have not been getting a lot of oxygen, right? Okay, so we need to administer broad spectrum antibiotics ASAP, right? While we're waiting on the culture and sensitivity to come back, we may switch it later, but we're going to do broad spectrum from the get-go because we want to try to cover as much as possible and kill whatever it is that's causing this issue, okay? And then again, the narrow coverage based on the culture results after we've administered broad spectrum. The other thing is we need to, because they have a low blood pressure, we need to address that, right? We need to do fluid resuscitation with crystalloids, okay? So that's going to help the hypotension. But what if we've given them, we've done all this and their CVP is a 13 and they're still low? They need not fluids, they need vasopressors, right? Back to the old hemodynamic monitoring. So it depends. We'll start them on fluids, and while we'll just hang fluids while we're doing all this. This is all happening literally. We're getting the cultures. We're starting the blah blah blah. We're giving the meds. We'll hang a bag of normal saline up there real quick. And we're doing all this within like 5 to 10 minutes of their arrival in the ER. Okay. And so we're going to start them on this, and then eventually hopefully we'll get an art line, and then we can get a CVP. And then if the CVP is high, we may like slow down those crystalloids to like minimum and then work on vasopressors, but we're going to need, other things. So just remember that. Okay. Supportive care also could include oxygen therapy. Okay. And again, like vasopressors, if the fluids aren't enough to support getting the blood pressure back up. Okay. But yeah. Okay, so now sepsis versus septic shock. Okay, so before we go deeper into septic shock, again, I know I've already kind of hit on it, but I want to make sure it's clear, okay, that you guys understand sepsis itself and how it progresses into septic shock. Okay, so I want you guys to think of sepsis like a wildfire that starts in like a very small area. Okay, so it has the potential to engulf and burn down the entire forest if it's not contained properly, but sepsis in and of itself isn't completely like affecting the whole forest yet, right? So sepsis is defined as a life-threatening organ dysfunction caused by the dysregulated host's response to infection. So there is a organ dysfunction component. It is affecting the whole body, but the whole body isn't collapsing yet, okay? So the pathophysiology involves the body's immune system overreacting to that infection, okay? And that causes widespread inflammation, increased capillary permeability, and those abnormal coagulation, okay? This results in a decreased tissue perfusion and organ dysfunction, okay? So just because the tissue is decreased doesn't mean that it's not getting necessarily enough per se, right? So clinical manifestations of sepsis can be subtle at first, okay? It might include fever, but it could also be hypothermia. It could be tachycardic, tachypnic, altered mental status. And then you can also see signs of organ dysfunction like decreased urine output. Okay, so if you recognize these signs early, it's super important because it's like if there's a wildfire in the forest, you want to notify it early and put the fire out before it completely burns down the entire forest, right? So when sepsis progresses, and the circulatory and metabolic abnormalities become so profound, right? Basically profound enough to substantially increase the mortality, the potential of death. It then evolves into septic shock, okay? So this stage is characterized by persistent hypotension, requiring vasopressors to maintain a mean arterial pressure of at least 65. I mean, really, yeah, we want it 65 or above, but like remember 60 is that magical number for your kidneys. We want wiggle room, so we want to maintain the MAP above 65, okay? And a serum lactate level of so let me go back to the MAP. Greater than or equal to 65, and a serum lactate level of less than 2 despite adequate fluid resuscitation. Okay, so sepsis does involve decreased oxygenation and perfusion to all your organs, but it's not to the point where you really need like the vasopressors and stuff to maintain adequate tissue perfusion. Okay. Sepsis needs fluid resuscitation. You need to do all the things, the cultures, possibly oxygen therapy. You need to get the antibiotics and all that kind of stuff, right? Because we don't want it to turn into true shock, where shock is like the failure of the system to at all. So, where it goes to the point of vasopressors. Okay. Now there are some other criteria that we're going to go into in just a second, but that's kind of the distinction between the two. Okay. So one of the ways is Sears criteria. Now, this is not the only way that we classify and identify sepsis versus septic shock, but this is a common one. There's another one that's like, there's an acronym called SOFA or QSOFA. I'm only going to go into Sears criteria for you guys here. Wherever you go work, they may have a different algorithm for you to follow and acronym for you to remember the different components, but we're going to go with Sears here. Okay. So what is Sears? Okay. So it is called Sears, SIRS. It stands for the Systemic Inflammatory Response Syndrome. Okay. So this is criteria that's used as a screening tool. Okay. So it includes, when you get your patient, you assess them. And if they hit 2 of these 4 criteria, they now meet Sears criteria, and they're going to fall into one of these categories: sepsis, severe sepsis, septic shock, or MODS. Okay. So temperature greater than 38 degrees Celsius or 100.4 degrees Fahrenheit, or less than 36 degrees Celsius, which, okay, so some people say 36 degrees, which is 96.8. This picture on the screen says less than 95. You don't have to remember that. Just know it would be hypothermic or hyperthermic. It could be one or the other. Okay. You don't have to remember the specific numbers on the low end, but remember the 100.4 or higher. Heart rate, tachycardia greater than 90. Now, this is where some people might stop, because you're like, wait, greater than 90 is tachycardic? So like 94 is considered tachycardic when it comes to Sears? Yes. Okay. So any heart rate greater than 90 is considered tachycardic when you're looking at Sears criteria. So if they have a heart rate of 96, check mark for tachycardia. Okay. Respiratory rate greater than 20 breaths per minute. But if you have a CO2 monitor and it's less than 32, they also meet this category 2 for a respiratory involvement. And then white blood count. So you get your CBC back and it's greater than 12,000 or less than 4,000. Okay. Or more than 10% immature band. So that's another part of CBC. I'm not going to make you remember that, but that is another thing of the criteria. So a patient that has 2 or more of these criteria in the presence of a suspected or a confirmed infection, you consider them septic. So we start with sepsis. Okay. However, okay, it's important that I note that there are limitations of Sears. Okay. So it is a helpful screening tool. It's not specific, and it can present non-infection conditions like trauma or pancreatitis as septic when they're not. Okay. So remember that. Okay. So you need to have that suspected or confirmed infection, and there's no other reason why they have low blood pressure like that you can think of. Okay. Additionally, okay, some septic patients, especially the elderly or patients that are immunocompromised, may not meet these criteria yet, but they're still critically ill. Okay. So while Sears provides a useful framework, it should be used in conjunction with clinical judgment and other assessments. So now if they are, if they're septic, so if they meet 2 or more, they're septic. So now sepsis with greater than 1 organ system dysfunction. So hypotension, alternate mental status, acidosis, oliguria, that's no urine in case you don't know, acute respiratory distress disorder, ARDS, whatever, that you become severe sepsis. So a lot of people actually immediately go into the severe sepsis category versus the sepsis. I mean, a lot of people do, because by the time they're seeking a healthcare, they're probably in severe sepsis. Now it becomes shock, okay, when the severe sepsis with hypotension is unresponsive to fluid resuscitation, and now we have to give those vasopressors, okay? That's when it becomes shock. Now, what MODS is it's 1 organ system, greater than 1 organ system requiring interventions to maintain homeostasis. So there's the next slide, we're going to talk about that more. But these are the Sears criteria that a lot of people use to define the different stages and the different progression. And you're looking at the mortality rate. So 16% of people that go to sepsis, mortality rate. 20% of the people that go into severe sepsis have a more like pass. Septic shock, 69%. I want you to look at those numbers, okay? Because if it's already reached that point, then they probably haven't been perfusing organs for a while. And if that's the case, then you have a whole bunch of cellular death across the body and multiple organs, right? And once that tissue dies, it's not coming back. So now you're going to have decreased liver function, decreased kidney function, decreased everything function, that you need those to be working at full steam to even overcome the initial infection together. Do you see how like it's like a snowball, like a vicious cycle? Like it just doesn't help, right? So that's why early intervention and perfusion is so important. Okay, so MODS, a little bit more about MODS. Okay, MODS stands for Multi-System Organ Dysfunction Syndrome. So this is when the body's failure extends beyond just one organ, and it's like a cascade of dysfunctions that a lot of times leads to fatalities, okay, but doesn't always, okay? So the pathophysiology is complex. It involves uncontrolled inflammation, immune dysregulation, microvascular coagulation, which leads to tissue hypoxia. So it's all those things in sepsis, severe sepsis, septic shock, and into MODS, right? So risk factors include severe infections, prolonged shock states, significant trauma. So you can go into MODS from other forms of shock, by the way, okay? And I have this sepsis symptoms up here, and I feel like that should have been on a different slide, but you can read it, pause it. That's some symptoms of sepsis. So sorry about that. Anyways, back to MODS. Okay, so MODS is something that happens with any form of shock, and it can lead into MODS. Okay, so like I said, the risk factors are any form of shock that is prolonged, and you can go into this. Okay, so management strategies. Our main goal is supporting failing organs. So mechanical ventilation for respiratory failure, dialysis for renal failure, and also preventing those secondary infections and addressing the underlying cause of why the patient is having shock and lack of perfusion. So more on sepsis. Okay, so early recognition. So as emergency nurses, I've already kind of went over this. We're often the first person that sees a patient before the physician even comes near that patient for a long time. Okay, so we have to have early recognition because that could be the difference between life and death. If we triage a patient in the front, we make them go sit out in the waiting room for 2 hours before they even are brought back. That's time is muscle, right? So if we identify, this is why a lot of people have code sepsis now, right? So that is our best weapon at helping these patients is that early detection. So like I brought up SEERS criteria, okay? Like I said, depending on your facility, there may be different like screening tools for it, okay? But basically the steps to identify these patients, you're going to do that initial triage assessment, get a vital signs, okay? You're going to pay close attention to those vital signs, mental status, and any symptoms that represent organ dysfunction, like lack of urine, respiratory issues, that kind of stuff, altered mental status, right? So you'll activate code sepsis protocol based off of your facility, okay? That's sounding the alarm. That should bring more resources and functions to this patient where everybody identifies that time is of the essence. You need to get a IV access ASAP, okay? You really would like to have 2 large bore IVs because we need to give fluids. We need to also be able to do lab draws. We need to be able to give possibly vasopressors. We need to give an antibiotic. So we really need at least 2 lines, okay? We want to draw blood cultures, and from 2 different sites, right? And before the antibiotic administration, I already went over that. We need to get a whole bunch of lab values, but including lactate. I don't know if y'all know this, but a lactate has to be on ice. So send somebody to go get a bag of ice. So when you're drawing blood, you can immediately put it on ice and you get accurate levels when it comes back from lab. If you don't know this right now, it's okay. You will learn it, but you'll learn from a mistake and then you won't ever do it again. Then you want to, as soon as you get all of your cultures, you've got your lines in, you've got all your labs sent off, you need to start fluid resuscitation. Again, I'm probably going to throw a bag of normal saline on this patient and I'm just going to basically let it flow as fast as the pump will let it go. Okay. So we want to address that hypotension and hypoperfusion immediately. Okay. So then we're going to start getting labs back. And once the cultures are obtained, we can start antibiotics. We're going to start on a broad spectrum. But one of the things you need to remember is the reason why I said we're going to have fluids before we give antibiotics, but the goal is antibiotics, is because a lot of times as soon as the antibiotic goes in and it lyses or starts killing some bacteria, especially if it's gram-negative rods, they can release endotoxins that can cause more vasodilation. And a lot of times, as soon as you start antibiotics, blood pressure drops. So at least they already are hypoperfused with hypotension. I want to make sure I have fluids hanging so that we can make sure that we can perfuse these patients, right? Okay, so then the other thing, we're collaborating with people. We're getting all this stuff on. We're going to watch them. They're probably going to go to the ICU after that. And then tag, you're at ICU nurse. You can take over. So there's management bundles for sepsis. Again, we're probably going to be giving them maybe some supplemental oxygen, just so we make sure that the hypotension, what is in the system, is very well oxygenated to get to the things. This is kind of reiterating what we're already talking about. You can pause and read it, but it's pretty much what I've already been talking about. And so a lot of times when providers are putting in orders, they have a bundle and they just click it and then all these orders pop up. And these are just very standard for patients with sepsis. So back to shock. Remember, sepsis, septic shock. So persistent hypotension despite the fluid resuscitation and where we need vasopressors. Okay, this has that high mortality rate. Remember, it's like 69%. Okay, so we want to prevent patients from getting to this point. Okay, we really, really, really do. Just remember that, okay? And then when we do give vasopressors, the most common one is going to be norepinephrine. This is a drug I think you guys should go look out and go look up the indications, drugs, routes, mechanism of action, side effects. This is one that you're going to be giving for septic shock all the time. So norepi is very common in this, okay? The one thing I'm going to tell you, well, some of the things I'm going to tell you. So just remember, norepinephrine is stimulating those alpha adrenergic receptors, okay? So that causes vasoconstriction. That's vasopressors, vasoconstriction. That's going to increase systemic vascular resistance, which will increase blood pressure, okay? It also has adrenergic activity, which can increase the cardiac output, okay? So some of those side effects can include arrhythmias, but it can cause limb ischemia due to intense vasoconstriction and extravagation injury. So the problem with this one is it causes such great vasoconstriction all over your body to maintain that pressure that it causes such great vasoconstriction in like your fingers and your toes and the tip of your nose that there's nothing that gets to that tissue. And they, even without extravasation of like say it's in a central line, there's not the actual med getting into that tissue. It's just such powerful vasoconstriction that these patients sometimes end up getting amputations. And you've probably seen these stories on like TikTok or, YouTube or on the news and stuff. That this happens when patients, sometimes when they become septic, they end up getting amputations of fingers, arms, toes, whatever, as a side effect. But at least we were able to perfuse their heart, lungs, and brain, so they're still alive. But it's collateral damage. So you need to go look up norepinephrine and like really look into it and just become familiar with it. So that's module 7. We talked today about the different shock types. You need to be able to distinguish the difference between each shock type and understand hemodynamically what is happening with each one of them. Okay, so you need to know the difference between the 4 different types. And I know we didn't really go over obstructive today, but we're going to go over that in a later model. But it won't be on the exam for this module. So the three main ones that we went over today, including within distributive shock, you need to know the difference between anaphylaxis, sepsis, and neurogenic. Okay, that concludes module 7. Don't forget to read your readings and learning objectives. And you guys have a great day.